Okay, so welcome everyone to this almost final session. We've made it through the last few days pretty well. And of course, for the best of the best papers, so we're in for our final treat just before the keynote session at the end. We'll run this by running through the papers consecutively and then come to the end and everyone's welcome to ask questions. So we'll start up with Nadine with her spinal fusion post-NICE guidance. And Helen, if you could start running that.
Good afternoon, everyone. I'm just going to share my screen. This presentation focuses on spinal fusion post-NICE guidance and asking the question, shall we pick up the baton? My name is Nadine Foster, and I'm really doing this presentation on behalf of a very large group of people involved in the BritSpine fusion workshop in 2018, and also a large group of people involved in the Picasso trial application. Lumbar fusion surgery is an operation to fuse the bones of the lower spine together to form a solid union, to stop instability in the spine and therefore to try to reduce pain symptoms. But there is very limited research to date. Several systematic reviews listed on the slide generally use the same trials and cohort studies and overall do not show a clear advantage of fusion, but some do show modest benefit for pain, function, and quality of life. When we look at the current status, therefore, of the evidence for fusion, the largest trial and the only one in the UK by Jeremy Fairbank and his team, with over 300 patients, found a modest benefit for physical function in favour of fusion surgery versus a rehabilitation programme based on exercise and cognitive behavioural therapy. The Oswestry Disability Index difference of just 4 points was just statistically significant. But there was a 16 to 20% complication rate in short to medium term. And no previous randomised trials have compared fusion with placebo, yet we really do now understand that orthopaedic surgery has considerable placebo effects from trials on other orthopaedic conditions. Therefore, the outcomes from fusion surgery compared to continued conservative or non-surgical treatment are uncertain, and that, of course, led to the NICE guidelines recommending fusion not to be used unless as part of a randomised trial. So the question is, shall we pick up this baton and see if we can achieve this as part of a randomised trial? There are many challenges in this field, and I've listed only 6 here. I don't have time to discuss them all, but you might reflect on these afterwards. The reality is, if this were simple, it would already have been done. So what did we do? Well, 2 years ago, we hosted a large workshop here comprising SBPR and BAS members, and had over 120 clinicians and patient representatives, where we developed what I would call the early PICO for the trial, so identifying patients, intervention, comparisons, and outcomes. Again, in the interest of time, I don't have time to go into all of this, but essentially what we did is go through each of these areas that would basically underpin the structure of a new randomised controlled trial. Following this, the HTA, that's the Health Technology Assessment Programme, called for a trial in November 2019. And to answer the question, for people with low back pain, is lumbar fusion more effective than conservative care? And they largely left a lot of the decisions around the specifics of the PICO up to the applicant and trial team. We then moved forward with putting a trial team together, and we called that trial Picasso. And we had a co-chief investigator model, a large interdisciplinary team with the right expertise, a clinical advisory group that many of you were involved in over several teleconferences and Zoom meetings, as well as 2 patient and public involvement workshops in order to submit a bid in April 2020. We offered a feasibility phase followed by a main randomised controlled trial with an internal pilot, a large multi-centre 3-arm parallel group trial. And here you can see that design. So essentially comparing lumbar fusion surgery versus continued conservative care versus placebo surgery. As far as we're aware, the HTA received 3 applications, and to our knowledge, none were invited to stage 2. And when this happens, the HTA revisits the commissioning brief and often amends it before putting out a further call for a trial. So I'd like to use this opportunity to thank everyone who's been involved in this journey so far, and to suggest that perhaps that journey isn't yet over. My question I'd like to leave with you is our spine community ready to respond if the HTA recall for this trial? Thank you very much for your attention.
Thanks very much, Nadine. We're going to move on to our next presentation straight away, and you're welcome to all continue to place questions, which we'll get to at the end in the chat box. So if we can continue with our next paper from Constantino and the clinical and cost effectiveness of stratified care model for patients.
Good afternoon. My name is Kika Constantino. I'm a senior clinical lecturer at Keele University and a consultant spinal physiotherapist. I would like to present to you the results of the SCOPIC trial on behalf of the trial team. The study was funded by the NIHR Health Technology Assessment. The aims of the SCOPIC trial were to compare the clinical and cost effectiveness of a stratified care model versus usual non-stratified care for patients in primary care consulting with sciatica. In the SCOPIC trial, we expanded on our well-established stratified care model for non-specific back pain, the START back model, to include indicators of sciatica severity that we found to be associated with referral to spinal specialists. These characteristics include pain below the knee, intensity of leg pain, sensory deficits in a dermatoma distribution from the clinical assessment, and interference with ability to do one's job or jobs around the house. The stratification algorithm is published and freely available. We recruited nearly 500 adults who were randomized to the stratified care arm or usual care arm. The stratification algorithm allocated patients in one of 3 groups. Patients in group 1 were matched with a brief course of physiotherapy in a couple of sessions. Those in group 2 were matched with a course of physiotherapy with an average of 5 to 6 treatments, and those in group 3 were fast-tracked to have an MRI scan within 3 to 4 weeks from randomization, and then to see a spinal specialist for further assessment and management plan. The inclusion criteria for the trial were adults with a clinical diagnosis of sciatica symptoms, having a mobile phone or a landline, and able to read and communicate in English. Exclusion criteria, your usual suspects here. Outcome measures. The primary outcome was first time to resolution of symptoms using text messages collected every week for the first 4 months and every month for the remaining of the time, or until 2 consecutive responses indicating resolution of symptoms. We also collected secondary outcomes with questionnaires at 4 and 12 months. This also included healthcare use and work loss or work productivity for the purposes of cost-effectiveness analysis. Next slide shows some key baseline characteristics per stratification group, and as you can see, the levels of disability, leg pain, and depression increase from group 1 to group 3. The primary analysis is time to event. Event defined as resolution of symptoms if patients indicate that they are completely recovered or much better. The next slide shows the curves for time to resolution of symptoms between the 2 arms, and as you can see, they're quite similar between the groups. Patients in the stratified care group overall recovered within 10 weeks. Those in the usual care arm within 12 weeks. The median difference of 2 weeks between the groups is not statistically significant. In terms of secondary outcomes, patients in both trial arms made similar good improvement over time from baseline. The next slide shows you the cost effectiveness plane and analysis. The bottom line here is that the stratified care model we tested was not more cost effective compared to usual care. In conclusion, the stratified care we tested in this trial led to 2 weeks faster improvement, which was not statistically significant. Overall, it was not more clinically or cost effective compared to usual non-stratified care, where most people received the course of physiotherapy. Most patients in both arms improved relatively well and in similar ways over the course of 12 months. We found that about a quarter of patients in both arms did not report completely recovered or much better at any time point. Results from this trial do not support change from the current stepped care model. Many thanks for your kind attention.
Okay, right. Thank you very much. And again, do feel free to add your questions below, and we'll get to them at the end of all of our talks. And our next presentation is from Hussein Al-Ghafi from the fibular allografts as a salvage option in pedicle screw fixation revision. We can continue with that.
Hi, I'm presenting our study on fibular allograft as a salvage option in revision pedicle screw fixation. In revision spine surgery for pseudoarthrosis, a significant amount of pedicle bone loss may be present, resulting from screw windshield wiper effect. It can be seen in preoperative CT scan, as well as intraoperative assessment when the largest screw diameter in our institution, which is 9 mm, didn't have adequate purse. The current option for revision are cement augmented screw fixation, disadvantage, extravasation, pulmonary embolism, anaphylaxis, and screw loosening. Another option is custom-made large diameter screws, disadvantage, high cost, screws specially ordered, delaying surgery. The objective of the current study is to present the author experience with this technique. The fibular allograft is cut into 50 mm strips. The cost of 1 unit of fibular allograft in our institution is $570. After removal of the loose screw, we use a curette to clean the screw track. Be aware of any wall deficiency, especially medial wall, to avoid dural or nerve root injury. We insert 3 fibular allograft strips and we leave them prominent to avoid any graft migration anteriorly during screw insertion. We use 6 mm tab. After that, we insert screws 8 or 9 mm in diameter. After complete insertion of the screw, we trim the prominent part of the graft. This is a 59-year-old male patient, diabetic with vitamin D deficiency. He had 4 previous lumbar spine surgeries. He presented with severe low back pain as well as radicular pain in the right lower extremity in S1 dermatome. This is a preoperative CT myelogram sagittal view. Showed a halo around S1, L5 as well as L1 screws. This is a coronal as well as axial cut. Intraoperative picture showing the surgical technique. The picture on the left-hand side is preoperative CT scan of this patient with a marked halo around the S1 as well as L5 screws. On the right-hand side is 12 months follow-up CT scan, showed complete incorporation of the graft. We did L5 S1 interbody fusion to protect the screws, and the picture on the left-hand side showed solid fusion. This is another case with L5 loose screws, halo around the screws in the coronal and the axial cut. The picture on the bottom is 2 years follow-up CT scan with full incorporation of the allograft. This technique was used in 30 consecutive patients, 18 men and 12 women. The mean age was 52 years. The clinical outcome assessed by ODI as well as vision analog score for the back and the leg pain. CT scan performed at 12 months to assess femoral allograft incorporation along the screw track, in-screw loosening, and interbody as well as postlateral fusion. We have achieved excellent pressures with all screws intraoperatively. At mean follow-up of 29 months, there was significant improvement in the ODI as well as vision analog score for the back and the leg pain. CT scan obtained at 12 months showed incorporation of the femoral allograft and solid fusion in all patients except one. This is a novel technique with encouraging clinical as well as radiological results. It allows biological fixation with graft incorporation. It avoids complication with cement augmentation. The limitation of the current studies are a retrospective study, a single surgeon series, lack of biomechanical data supporting the results. In conclusion, femoral allograft is a viable option in revision spine instrumentation. The advantages are available on the shelf in most hospitals, employed without specialized instruments, significant cost saving when compared to custom-made screws, allow biological fixation at screw-bone interface. Thank you.
Okay, thanks very much. And we'll move on to next talk from Andrew Dixon on the assessment of clinically relevant measures for injection of intervertebral disc therapies.
Hello, my name is Andrew Dixon, and I have the pleasure of sharing with you some of my PhD work, which aims to assess clinically relevant measures for injection of intervertebral disc therapies. A proposed treatment for early-stage disc degeneration is injecting a biomaterial into the disc to restore its biological or mechanical properties. There are several biomaterials currently under development which show potential, one of which has been presented here at BritSpine in the past by some of my colleagues. There are several important questions that need to be answered that will help with the translation of these materials into the clinical environment, and the work I'm presenting today is trying to assess how much of a therapy should be injected. The reason this is so important is that result in unsuccessful treatment, whilst over-injecting could potentially cause an increased risk of herniation. Therefore, the broad aim of my work was to identify clinically relevant measures that are quantifiable and can indicate the mechanical performance of an injectable biomaterial. To actually do this, I used an in vitro sequential state testing method, which began preparing 22 bone disc bone units from bovine tails. These units were then put through a cyclic compression test in their native state, where the specimens were submerged in a fluid bath and tested over 1,000 cycles of physiological loading. The units were then subjected to an enzymatic
Apologies, I'm not quite sure what's happened there.
Okay, are you able to just have a quick look if you can stop that one and just...
Yeah, I'm not quite sure. I think someone touched. Which one were we on? We were on Andrew Dixon.
Correct.
It looks like it's been deleted out.
Okay, could you, if we can pause the one that's playing, and we'll correct that. We can continue with the uncertainty and intervertebral tethering, but if you could stop that one. I won't touch it, I'll let you do it.
Just bear with me 2 seconds. Neil, we're just going to go on to this one for now, and then we'll come back to the other one if that's okay.
That's fine. I can hear one playing in the background, though. So I can hear Mr. Al-Ghafi's presentation playing. So if that could be paused, please.
I can't see that presentation, so something's happened.
Okay, don't worry.
If I play this one, just let me know.
Okay.
It's a real honour to be invited to present in this session today. I plan to discuss the results of a study designed to improve a surgeon's ability to predict post-operative radiological outcomes following anterior vertebral body tethering for scoliosis. This work was conducted at the Mount Sinai Hospital in New York as part of a BOA-awarded travelling fellowship. I have no disclosures to declare. Since its first implantation in 2008, vertebral body tethering has been shown to offer the ability to progressively correct scoliotic deformities without a fusion in select patients. 3 North American centres recently published their promising midterm results. Yet when compared with outcomes following traditional fusion surgery, a relatively high number of cases still fail to achieve clinical success. Several unanswered questions remain, and over time we hope to better understand what cases are suitable for vertebral body tethering, when the optimum time to intervene is, and how the procedure compares to a fusion in the long term. The assessment of curve flexibility not only assists in the classification of different curve types, but it also influences the surgical approach and selection of levels. The fulcrum bending radiograph was first described in 1997 and is one of several methods to assess curve flexibility. Compared to supine bending, this has been shown in several studies to better predict the radiological outcomes following spinal fusion for scoliosis. The Hong Kong group also went on to describe the fulcrum bending correction index, which provided us with a means to better compare the effectiveness of various surgical techniques by controlling for curve magnitude as well as stiffness. For those in the audience less familiar with the technique, a bolster is simply applied to the lateral aspect of the patient in line with the apex of the deformity. And by ensuring the ipsilateral shoulder or hip is off the table, we're able to maximise the corrective force applied to the spine before an X-ray is obtained. So with this in mind, the primary aim of this study was to determine whether fulcrum bending radiographs can provide a reliable estimate of expected curve size on first erect radiographs in idiopathic patients undergoing VBT. We also sought to assess how spinal flexibility influences the correction achieved with a tether device. To our knowledge, this factor has never been considered an important screening tool for patient selection in the published literature, even though we knew from experience with traditional fusion surgery that larger, stiffer curves are more challenging to treat. An IRB-approved retrospective study was performed involving 38 patients over a 5-year period. All had a diagnosis of adolescent idiopathic scoliosis with an average age of 13.3 years. A number of exclusions were made to maximise homogeneity across the cohort, and all underwent a thoracoscopic procedure after preoperative evaluation with a fulcrum bending radiograph. A comparative intervention was not required for the purposes of this study, and in terms of outcomes, Cobb angle measurements were compared before and after surgery, providing us with the data to evaluate our primary objective of assessing the correlation between the two. Our secondary goal of assessing the influence of curve flexibility was achieved by ranking patients according to their fulcrum flexibility rates, then separating out the top and bottom quartiles, which gave us the ability to compare flexible and rigid cohorts. In terms of general outcomes, VBT achieved an immediate improvement in curve size with a correction rate averaging 61%. We also noted a significant improvement in the rotational profile of patients as measured using a scoliometer. In this cohort, the fulcrum bending correction index was almost 100%, which shows that vertebral body tethering is able to match the Cobb angle shown on a fulcrum bending radiograph. To answer our primary objective, bivariate correlation was performed and demonstrated a strong correlation between fulcrum bending and the first erect Cobb angle. We then went on to use a stepwise linear regression model to develop a predictive algorithm for determining postoperative Cobb angle in the clinic by multiplying fulcrum bending Cobb by 0.65 and adding 7.5 degrees. To answer our second objective, a student t-test was performed to compare the outcomes between flexible and rigid curves. We can see a significant difference between the groups for almost all assessment parameters, proving that those with larger and stiffer curves respond less well to vertebral body tethering, at least initially anyway. The fulcrum bending correction index in this case was similar between both cohorts, demonstrating that VBT is able to match the preoperative fulcrum bending radiograph, but this leaves us with the question as to whether this is enough. To conclude, this is the first study to demonstrate the predictive ability of a fulcrum bending radiograph when applied to vertebral body tethering. We now know the fulcrum bending Cobb angle is highly likely to mimic the initial postoperative Cobb angle, which we define as time point zero for the growth modulation process. This study also confirms rigid curves are larger, stiffer, and less amenable to correction using the vertebral body technique, and provides basis for further work comparing the association between curve flexibility and clinical success. Thank you for your time.
Okay, hopefully that's the end of our technical glitches, but we'll be moving on, I think, now to Zacharias Silk, reducing uncertainty in anterior vertebral body tethering, predicting. Nope, not doing that. Okay, well, let's see what we get up, Helen. See what you load up next.
Good afternoon. It's an honor to be the last presenter of this meeting, and I would like to thank my co-authors from Edinburgh in Sweden. Today, I would like to present our study on the spine and chest deformity in AIS in relation to the volumes of the lung, airways, and pulmonary function tests. We have no disclosures. As we all know, AIS is a three-dimensional deformity, not only of the spine, but also of the complete chest and trunk. By the rotation of the apical areas, also the ribs and the chest deform, and this may cause restrictive pulmonary impairment. However, these two studies have shown that there is an apical lordosis in AIS of the thoracic apex, and this may lead to intrusion of the spine into the chest and to narrowing of the bronchi on the right side. Therefore, the aim of this study is to describe the relation of the chest spinal deformity, the narrowing of the bronchi, the lung volumes, and the pulmonary function test in patients undergoing AIS surgery. We were able to collect 85 preoperative thoracic AIS patients that underwent pulmonary function tests, standing x-rays, and supine expiratory chest CT scans. Those were required for preoperative planning or navigation surgery. It is a cross-sectional study in 2 European centers. And for the pulmonary function tests, we used the height corrected for the loss of height caused by the scoliosis. We measured the conventional radiographic parameters such as Cope angle and thoracic kyphosis. And on the actual images of the apex on the CTs, we measured several chest deformity parameters, including the hemithoracic width ratio, the chest torsion, so the relative position of the sternum relative to the spine, the endothoracic hump ratio, which represents the intrusion of the spine in the corrected sagittal plane of the apex, and the surface area of the spine relative to the total surface area of the chest, which is called the spinal intrusion index. We also measured the complete 3D lung volumes on the left and the right, and we completely segmented the airways, the first 3 generations of the airways on the left and the right, and calculated the cross-sectional areas of the different parts of the airways. These are, and as you can see, the airways that are most affected by the apex in AIS are the connections to the right, middle, and lower lobe. These are our results. Of the 85 patients, 41 had a FV1 or FVC predicted below 65%, and 17 patients had an obstructive lung disease based on the FV1 FVC ratio. When we compared the AIS patients with and without impaired pulmonary function, we observed that the ones with impaired pulmonary function had a smaller thoracic kyphosis, they had a larger rib hump, they had increased spinal and thoracic rotation, they had a narrower right hemithorax, they had increased intrusion of the spine into the chest, and they had relatively smaller lungs on the right side and compression of the right-sided bronchi. All chest deformity parameters correlated significantly with the FV1 and FVC, and the rib hump index with 0.52 was the strongest correlate. Increased spinal intrusion correlated with right-sided bronchial narrowing and relative right lung volume loss and decreased FV1 and FVC. And when we combined all characteristics, we were able to explain 57% of the variance in FV1 and 54% of the variance in FVC. In conclusion, the chest intrusion by the endothoracic hump in AIS is related to the right-sided bronchial narrowing and lung function loss in the preoperative stage. Ventilatory dysfunction in thoracic AIS is not only restrictive, but frequently has an obstructive component, especially in patients with pleurodyscoliosis or hyperkyphosis and a flat chest. And the rib hump index is the most predictive chest parameter for lung function loss. Thank you.
Okay, and Helen, if we could carry on with that last one, we should be able to reload that. Apologies, Mr. Dixon.
Hello, my name is Andrew Dixon, and I have the pleasure of sharing with you some of my PhD work, which aims to assess clinically relevant measures for injection of intervertebral disc therapies. A proposed treatment for early-stage disc degeneration is injecting a biomaterial into the disc to restore its biological or mechanical properties. There are several biomaterials currently under development which show potential, one of which has been presented here at BritSpine in the past by some of my colleagues. There are several important questions that need to be answered that will help with the translation of these materials into the clinical environment, and the work I'm presenting today is trying to assess how much of a therapy should be injected. The reason this is so important is that under-injecting could result in unsuccessful treatment, whilst over-injecting could potentially cause an increased risk of herniation. Therefore, the broad aim of my work was to identify clinically relevant measures that are quantifiable and can indicate the mechanical performance of an injectable biomaterial. To actually do this, I used an in vitro sequential state testing method which began preparing 22 bone disc bone units from bovine tails. These units were then put through a cyclic compression test in their native state, where the specimens were submerged in a fluid bath and tested over 1,000 cycles of physiological loading. The units were then subjected to an enzymatic degeneration procedure, which we have demonstrated produces degenerative mechanical features in a statistically significant manner. After this, the discs were subjected to the same cyclic compression protocol in their new degenerate state. The discs were then treated with a peptide hydrogel using 25 gauge needles on a syringe driver with an integrated force sensor. This is reflected in the image highlighted on screen. The injection was stopped at a set force, and volume and force were used as the main measurables for assessing restorative properties of the hydrogel. Finally, the discs were subjected once again to the cyclic compression tests in this new state, the treated state. So, for the specimen, we measure the mechanical properties in the native, degenerate, and treated states. This allows us to use the specimen as its own control, and we can measure how successful a treatment has been in restoring native mechanical properties. So mechanical stiffness was used to assess how good an indicator volume and force are at predicting restoration. And for this work, restoration was classified as the difference in the stiffness between the native and treated states. So a low restoration represents an undertreated disc, and a high restoration represents an overtreated disc. The results indicate that volume, the graph on the left, has a strong relationship with restoration, whereas force, the graph on the right, has a weak relationship to restoration. Overall, this is mainly thought to be because volume is a direct measure of the state of the disc, whilst force is an indirect measure of the disc's pressure. Overall, this work has demonstrated an in vitro test methodology to evaluate clinical measures for injectable therapies. This work has evaluated two measures, injection force and injection volume, where force demonstrated a weak relationship with restoration, but may be useful to provide extreme upper and lower limits for injection. We have found that volume appears to be an important indicator and a very good indicator for disc restoration. Finally, the next step in this project is applying these techniques to an in vivo ovine model to assess longer-term effects of these injections. In this work, there is no conflict of interest to declare. Thank you very much for listening. I'd like to thank the EPSRC for funding this work, alongside my co-authors for all their help.
Okay, thank you very much. So we've got those, and we should have a chance for some questions. And if you don't mind, I may just start by asking. Nadine, could I ask if you can hear me? Just with regards to your trial and the fact that, unfortunately, this has not gone through, can you make some suggestions as to how it can be achieved when I assume the surgical community has an incentive to want to push this through? What should we do better next time?
Can I check? Can you hear me, Neil?
Yeah, I got you.
Like all these big commission calls, I think the ball is firmly back in the funder's court. And so I think whilst it is a little bit frustrating, I think largely we're in a position now of waiting to see what the HTA want to do with their commissioning brief and whether they want to amend it. And then for our spine community really to be able to respond to that. So the previous brief left a lot up to the applicant team to decide, including the details of the patients, the intervention, comparisons. All the HTA said in the last one, particularly was comparison. They wanted the main comparison to be continued conservative care, but they also asked teams to consider whether they would like to also include a placebo surgery arm. And then, of course, finally, the O of the PICO, the outcomes. So that they left quite a lot up to teams to decide. And I think we did a reasonably good job of getting reasonably good consensus around all of those discussions to put together a trial bid. I think we have to wait and see what now the HTA want to do, because clearly whatever they thought they wanted, they didn't get it in the 3 bids that were submitted.
Do they tend to feed back that detail, or is it very one-way direction discussion this?
So some of you will already know that the HTA, I think, like many of the NIHR funding panels, they try to be reasonably transparent. You can look at the minutes of the meetings and the key feedback points that were provided on their website. So we did receive some feedback on our bid, as I'm sure the other bids did as well, but actually very brief feedback on a stage 1 bid, Neil. Okay. So unfortunately, none of the teams got to the next stage, which is where more of the detailed peer review would happen at stage 2.
Thanks, Nadine. And then, Hussein, could I ask you, if you don't mind, with regards to your assessment of your CT scans and your loose screws, I did wonder whether you made any specific effort to exclude any low-grade infection peri-screw, whether those screws were routinely sent off for microbiological assessment or lab assessment to look for low-grade infections, or did you proceed straight away to bone grafting?
Thank you. We routinely do for this patient before surgery, ESR and CRB and CBC, and all of this patient, they were like within normals, and we do stat-gram stain swab during surgery, and we do culture as well during surgery. And none of this patient had infection. But there's some currently now, there's current thought that any non-union, there is kind of minimal infection go by. Some people believe that, but we didn't find any really clear infection in our group.
Thank you. Mike, do you want to proceed to some of those questions from
Yeah, thanks. Is Kika there?
Unfortunately, Kika's not in the audience.
Okay. Question to Zach then, if you would. Firstly, Zach, in terms of VBT, I understand that it matched the Fulcrum Bending Correction Index, but do you think that is the only measure of the value of VBT compared to conventional fusion?
Thanks, Mr. Greber. Can you hear me okay?
Yeah.
So obviously VBT is designed as a growth modulatory procedure, and really that's it's going to be a factor of what you can get the patient to at the time of surgery and how much time they've got ahead of them in terms of growth. Comparing it with fusion is probably not the right way to go with this, because the expectation is the maximal correction achieved at time of fusion will happen there and then. You wouldn't expect too much of a change. In fact, you'd expect possibly some loss of correction rather than improvement. So this is really a sort of a practical study, really, to try and filter out suitable patients for the technique. And one thing that's quite interesting from the literature is we've not really seen a huge amount of reference. In fact, actually, I only saw it in the most recent paper published in December 2020 by the Myangi group, but there was only one small reference relating to curve stiffness, and this was very much after the fact, rather than used to screen patients for inclusion, because one would sort of, I guess, rightly conclude, or possibly conclude, I don't think it's been shown, but stiffer, larger curves may not be suitable for this technique. And so this was really designed to try and give the clinician a screening tool in clinic so that they can manage patient expectations as best as possible.
Thank you very much. Next question for Dr. Schloss. Are you there?
Yes.
Yes, thank you. Interesting paper. A question from Rajat Verma. We don't normally do CT scans if we're not using image guidance, which is the majority of scoliosis operations in this country, in AIS. Should we be doing it, and what would persuade us to do it routinely based on what your findings are?
I think ideally we should minimize the radiation exposure to the adolescent idiopathic scoliosis patients. And I think there's not a place for routine chest CTs in AIS. This study was purely to describe the pathophysiology of the bronchial narrowing and the impaired pulmonary function in AIS patients. But however, if you in the clinical setting consider to do a chest CT in AIS patients, I think it's only worth it if you do an expiratory phase CT, because then you can detect the bronchial narrowing or the atelectasis. And I would only consider it in patients with clear pulmonary symptoms and with lordosis on their lateral full spine X-ray, or the ones with a very flat chest, so a small AP diameter.
And just a question from me. I noticed that 48% of your patients had FVC less than 65%, if I got it right.
That's correct.
Have you just compared that to some of the other published data? It just seems to me a very high rate of reduced or sort of the PFTs.
So the largest study on pulmonary function in AIS is from Peter Newton from San Diego, and they have a similar amount of patients with impaired pulmonary function with the 65% cutoff. So that's similar.
Great, thank you. There's a question here for Andrew. Andrew, are you on the line?
Hi, am I coming through?
Yeah. Okay, Andrew, this is a question from Christian Lemay. There's a question on volumes and different levels of disc degeneration. And what measures do you think would be the most valid in determining what volumes one should inject clinically?
I certainly agree that degeneration and any fissures or any other observable things like that will have an effect on the volume. I think the other one is just the outright size of the disc, both medial lateral as well as claudial cranial. I think that it will be important to do something like MR imaging or CT scan prior, so you can get an idea of what kind of volume would be required alongside the degeneration level. So I kind of picture boundaries based on size of disc and degeneration level to give clinicians an idea of roughly how much should be injected.
Yeah, and Andrew, if I can ask you a question, because my understanding is that most of your specimens were probably a fairly homogeneous group. Is that correct?
Yeah, so I'm mostly looking at a single level at the moment in the bovine. Yeah. We have a controlled degeneration method, but my next study in my PhD will be moving over to human tissue, which won't have that homogeneity. So I'm quite keen to publish that kind of data soon.
Yeah, because I was going to ask you that question, because as the disc degenerates, the adequacy of the competency of the annulus, in fact, fails because it becomes, as it were, decompressed. And therefore, issues about your volume injectate and the force required may be very different from some of your present studies. And do you see any ways of perhaps dealing with those confounding variables?
I think that's one of the reasons I chose to look at force, and I'm potentially going to be looking at pressure in the future, because I think force is a potentially good indicator of any of these confounding variables, and it would allow a clinician to identify them with that data. You go, okay, I've injected very little, but my force is very high. That's possibly a problem, or vice versa. So yeah, I think just giving more data to the clinician is the main answer, and it'll allow us to know whether the therapy is actually appropriate for the given situation.
Thank you, Andrew. Neil, do we have any other questions coming up, or does anyone else? I don't know how many more minutes we've got, actually.
We're at our time limit now. I think we can take questions if there's anything pressing. So if anybody has anything they want to pop in at the last minute, they're welcome to. Otherwise, I think we can close that session. Thanks very much, everybody, and thank you to the presenters.